Hi, everyone. We'll get started. Thanks for coming this afternoon. My name is Jeff Weiler. I'm the coordinator of the Gray Center. For those that are new to the Gray Center is an entirely Foundation and St. Joseph's funded program with the mandate of improving the mobility and activity outcomes of the patient populations that we serve here at Parkwood, but through the lens of research and education, and creating partnerships throughout the city. One of the ways in which we are going to do that here at the Gray Center is by making investments in technology that allows our researchers to ask new types of research questions and allows better access to new cutting pieces of technology from our patient populations. This brings up a really important question now that's should be on the minds of many people, is that does this technology work? And this is a really important question because by 2025, the use of technology in rehabilitation is going to be about a $20 billion industry. So two questions come to my mind is A, does this technology work? And then B, if it does work, are we using this technology to our fullest? At the Gray Center, we have partner researchers that are asking these types of questions. And in this presentation, we'll talk about it with relation to stroke rehabilitation. And this research program is led by Dr. Robert Teasel, and his two research assistants are going to present some data on this particular question. And then following that presentation, we will have a panel discussion to reflect on the information that they're sharing. So with that, I will hand this over to Dr. Teasel, and he can introduce his team members. Thanks, Doc.
Thanks, Jeff, and thank you all for coming to our research presentation at the Gray Center for Mobility and Activity. For those of you who don't know, June is Stroke Month, and today we're going to have a research presentation and a panel discussion on the use of technology to support motor recovery following stroke. And so, you know, when we think about where, as Jeff said, where stroke rehab is going in the future, this kind of checks off a lot of boxes. And so I think the topic is quite timely. And in keeping with our goal at the Gray Center of trying to work to integrate the clinical with the research, we have a panel of researchers, clinicians, patients, and administrators. And so we're going to first start with two short presentations of the research related to this topic. They'll go back to back. The first presenter will be Marcus Sackley, and Marcus is the project leader for the evidence-based review in stroke rehab. He has a background in neurophysiology, and he's going to talk to us briefly about the evidence.
Marcus, you might have been frozen, but I think you're good now. If you want to unmute your mic, you can speak.
Apologies. Right. So as Dr. Teasel mentioned, I'm the project coordinator for the evidence-based review of stroke rehabilitation. And with the few minutes that I do have, I'd like to present essentially an overview of the evidence that does exist for technology and hopefully gain a better understanding and appreciation for all the different therapeutic options that are out there. So to briefly summarize, motor rehab is by far the greatest area in stroke rehabilitation and has both within the upper and lower limb about 2,300 RCTs. And roughly 65% of these trials investigate some form of technology. And I think importantly, it's roughly 50% of those technology trials have been published after 2015. So it's a large area of evidence and a rapidly growing area of evidence. The various technological modalities that exist within the literature can be roughly broken down into about 5 different categories. The first is the electrical stimulation, the second being magnetic stimulation, the third is robotics and electrical and mechanical devices. The fourth is virtual reality and other computer-based systems. And the fifth is other sensory motor stimulation modalities. And we'll go through all of these now. So electrical stimulation is by far sort of the oldest established type of technology that's used in rehab, and there are a number of different ways in which it's administered. The biggest category that we see is neuromuscular electrical stimulation, or its cousin, functional electrical stimulation. So we can see here that there are over 200 randomized controlled trials that cover the two administration types. And where NMES is simply repetitive or cyclic stimulation of muscles while a person may be seated or at rest, the functional electrical stimulation aims to stimulate muscles on a particular time basis to facilitate an actual task that's being performed. Additionally, there is nerve stimulation. So this is transcutaneous electrical nerve stimulation, also a large number of RCTs that study this. And this works as opposed to actually stimulating the muscle, just aims to stimulate the sensory nerves around the area. And although this is traditionally used for pain and the remediation of pain, the vast majority of these trials you see here, over 50 of them, actually focus on how this can improve function. And there's good evidence to suggest that this kind of sensory stimulation can help improve functional stuff with respect to both the upper and the lower limb. There's also in electrical stimulation, transcranial direct current stimulation, which is a non-invasive form of brain stimulation, where either through an anode or cathode, you can excite the brain, increase stimulation, or inhibit activity within a particular brain area. And this is used, as you can see, quite frequently in the literature as well. Finally, within electrical stimulation, we have our sort of invasive forms. Peripheral nerve implants and cortical nerve implants are a much smaller area of research, but are certainly more recent with respect to the evidence that's coming out, and a growing area and a growing therapeutic target. Now, for the second one, magnetic stimulation, there are again sort of separated into peripheral magnetic stimulation and non-invasive brain stimulation. The peripheral magnetic stimulation modality is a bit less well studied, but they operate on the same principle, where in that lower right-hand image, you can see that we can induce an electromagnetic field, either over a muscle, nerve, or the brain itself, to induce either excitatory or inhibitory stimulation to these areas. And as you can see that the transcranial version, particularly in the upper extremity, is very well studied with good evidence in support of its use under different stimulation types. Our third category, robotics and electrical mechanical devices, covers a wide range of different modalities, different administrations, but these can be roughly broken into two major categories. There are exoskeletons, which the mechanical joints of the robot actually match up with the human anatomy itself. And there are also end effectors, whereby there's connected at one distal point, and the robot aims to move the arm or the leg to the appropriate location. So in the bottom left-hand corner, you can see that A image is an exoskeleton, and the B image is an example of an end effector. And these are used with various different frequencies, depending on which limb is being treated. Exoskeletons being much more popular in lower limb and ambulation-related research. For our fourth category, we have virtual reality and computer-based systems. And again, these types of therapies can take on a lot of different modality types and administration types. There are a number of different custom virtual reality systems that have been built specifically for rehabilitation purposes. And these can take either an immersive form or a non-immersive form. So in the immersion, with technology advancing as it is, certain programs can have those head-mounted displays that we see in that image on the left-hand side there. And we can put the patient in virtual environments like grocery stores, kitchens, maps of their neighborhood even, to better have them practice tasks or improve upon certain functions within the actual environment itself. And additionally, there's another subgroup of commercial gaming systems like Xbox Kinect or Nintendo Wii, which aim to do a similar thing in a less immersive experience by increasing the activity of the patient and gamifying the actual rehabilitation experience itself. Now, finally, other sensory stimulation is a bit of a catch-all for all the other technological modalities that exist that I can run through a few examples with you here. Thermal stimulation is something that's being investigated to a lesser degree in the literature. And some of this is simply with ice and heat packs, but there are a number of technologies that are being used to deal specifically with certain frequencies of hot and cold. There's also muscle vibration techniques, either locally or full body muscle vibration, which is the example in the photo on the upper left-hand side there, that are becoming particularly popular in the lower extremity for legs and hips. There is sound wave and shock wave therapy. That's another technology that's used to a lesser extent in the literature, but does have some good evidence towards its effectiveness. And then there are also a number of visual and auditory stimulation that can occur, whether it be rhythmic auditory stimulation, which is commonly used for gait and mobility, or other biofeedback modalities, either EMG recordings, kinematics from different muscles, movements, etc., can be displayed either visually or auditory to provide feedback to that patient. And then, of course, brain-computer interfaces are an amalgamation of many different modalities, and those are also being trialed in stroke rehab, particularly in the upper extremity. I think it's important to note that for any of these categories, for any particular administration of therapy, these can often take the form of a combination of many of these different types, and working towards a particular intervention can often be a combination of electrical, magnetic, robotics, and virtual reality are often paired together. So they're not necessarily distinct in their actual application. Now, concerning the effectiveness of these different therapies, there are many different systematic reviews and meta-analyses that have been published for these technology types that I would encourage people to look at. Many of them do seem to be efficacious within stroke rehabilitation. Here, I'd like to present an example of the work that our group is doing recently on a network meta-analysis for upper extremity interventions. And this network meta-analysis really aims to just combine a number of different pairwise meta-analyses together. And we can see that these interventions here highlighted in red are all examples of technologies we've discussed, and importantly, are all significantly better than conventional care at improving Fugl-Meyer upper extremity scales, which is a measure of motor function in the upper extremity. So in short, I think without getting too detailed into each technology, many of these modalities used in a number of different ways have proved to be effective for stroke rehab, and will continue to be investigated in the future. So I'll hand it off to Amanda now.
Thanks, Marcus. So now I'd like to briefly present for everyone some of the findings from our group's work on a national survey among stroke rehab clinicians that we conducted over the last year. And really the impetus for this project was simply that based on the SRVR work, particularly with Marcus, there appeared to be a significantly large number of randomized control trials looking at various interventions to improve stroke-related impairments. But we didn't fully understand the degree to which these interventions were actually used in real clinical practice. So this curiosity was what led to our study. And so the objective for our project was to evaluate which stroke rehab interventions therapists were aware of, which ones they use in clinical practice, including their frequency of use, and to determine reasons why they may not be used. So on the next slide, if you flip, yep, thanks. I just wanted to acknowledge all of the authors because there's been a lot of work done by a lot of different people. The project was led with myself alongside Dr. Ricardo Viena and of course Dr. Robert Teasel, but a number of other researchers and clinicians were a part of the project. So what we did is conducted a large cross-sectional observational quantitative survey to disseminate across all of the Canadian provinces, not the territories. And we developed it in a way to obtain information from, again, those who provide direct stroke rehab to patients after a stroke. And to participate in the survey, clinicians had to have met 4 inclusion criteria. And so they had to have held one of the following professional roles. So there were physiotherapists or PT aides, occupational therapists or OT aides, recreational therapists, therapeutic rec specialists, and speech language pathologists. Again, they had to provide direct rehab care to those, and we only included adults who could read and write in English or French. And the French survey was developed in consultation with one of our well-known OT colleagues from Parkwood, Charlie in Spine. The next slide. So individuals were recruited using 2 strategies. We enlisted the assistance of all the professional regulatory colleges in each province to send to their general members, send out the survey. And then we also generated an exhaustive list of all the medical centers that provide stroke rehab as best as we could gather. And we contacted their overseeing coordinator, manager, or director. And through formal leadership channels, the survey was disseminated to all therapists within those settings. So using an online link, participants were taken to a survey hosted on REDCap, and it collected information from therapists on their place of employment, including the type of setting, its specialization, and a number of other program components. And then they were taken to a list of interventions. And it's important to note that for the purposes of this study, I'm only going to be talking about the interventions that were technologically based, not the non-tech interventions. And I'm reporting data on OTs and PTs only, collectively as a group. So for OTs and PTs, there were a total of 40 interventions in total, both technological and non-technological. And they were asked if they had heard of the intervention or were they aware of it. And using logic, if they said yes, then they were further asked to indicate if they used the intervention and how frequently. And if they said no, they were indicated to respond for what reason or reasons. They could respond to more than one. Next slide. So what we found, we had a completion rate of 302 surveys completed, 127 by OTs, 175 by PTs, which was a good response rate, with the large majority being female, a good chunk of them, almost 40% from Ontario, followed by Quebec and Alberta. 3/4 of the sample of OTs and PTs were working full-time. And interestingly, they had been employed for more than 10 years for 61% of the group. There was, I put the split here for academic rehab, which was about 21%, 34% for acute care, but there were options to indicate outpatient settings and freestanding rehab settings. So which were fairly evenly split. So quite a representation from various rehab settings. And then again, 2/3 of the sample was from a large urban setting, actually quite large, more than 100,000 of a population. So this slide might be a little overwhelming if you just first look at it, but on this slide, what you're seeing in the table is a list of all the technological interventions that PTs and OTs were asked to review and indicate whether or not they were aware and whether or not they used the intervention. So what I've done is I've actually grouped the technological interventions within those 5 main groups that Marcus was discussing. So what you can see here using the shading, the green shading really highlights areas where therapists, there were a large number of therapists responding that they were aware. And conversely, the red shading indicates where a very low number of therapists were responding. So what you can see in the awareness column is that there was greatest awareness of the technological interventions for FES, or functional electrical stimulation, followed by biofeedback, followed by neuromuscular electrical stimulation, virtual reality, and transcutaneous electrical nerve stimulation. Now, interestingly, awareness didn't always indicate or align with actual use of those specific technological interventions. So you can see that the greatest use was functional electrical stimulation, followed by biofeedback and neuromuscular electrical stimulation. So you see some interesting trends. For example, if you look at FES or biofeedback, even though a significant proportion of therapists were aware of the technology, that didn't necessarily mean that they used it. About only half of those therapists used them. Similarly, if you look at virtual reality, almost 2/3 of the sample was well aware that virtual reality existed, but less than 10% actually made use of this particular technological intervention. Next slide. So this chart is exactly the same as the other one, but I've reversed the shading so that it's obvious where the greatest non-use of interventions occurred. And when you start to look at the shading and the proportion of therapists responding, you get a sense that there are a significant number of interventions where a large number do not use the intervention. And so what we found is that with the exception of functional electrical stimulation, the majority of PTs and OTs reported that they do not use technological interventions in their clinical practice with stroke patients. And this ranged from 55.6% with biofeedback up to 100%. And those particular interventions you can see fell within particularly the magnetic stimulation group. Next slide, please. So this slide, again, what I've done here is I've listed the reasons for not using an intervention, and I've listed every single technological intervention, which is quite overwhelming, but I think the shading really helps to capture large trends. And so again, along the left-hand side, you see the different interventions sort of grouped within those 5 major categories. And then across the columns, you can see the different reasons for non-use, starting with awareness. So a therapist simply isn't aware that the intervention exists, followed by other reasons, including cost, time, lack of access, being unsure where to learn, the intervention lacking in scientific evidence, and the perception that using the intervention was outside one's scope of practice. So you can see overwhelmingly that the main reason for not using an intervention was because therapists were simply unaware that the technology existed in the first place. And then there were a number of other reasons provided per intervention. If we look at the next slide, what I've done is I've actually just pooled those reasons. So rather than looking by intervention, it's easier if you just look overall. And then it's really obvious to see what are the main reasons that PTs and OTs provided as the rationale for barriers to using technological interventions. In this slide, I've actually included the proportion that were simply not aware, so that you can see that that's the number one challenge. That is the primary barrier in this case. But on the last slide here, I've actually removed the not being aware reason within the data, so that you can actually just look at the other also modifiable factors. And then what you see is that lack of access becomes the reason for about half of the responding therapists, and then an equal distribution of the remaining ones, with 8% being only reported as lack of evidence as a reason not to use the technological intervention. So I'll stop here because I think this is a great place to start our discussion with the panel, because it really highlights some of the challenges that were reported by clinicians, and is probably a good jumping off point for discussion.
Thanks, Amanda. Now we're fortunate enough to have one of our senior administrators at seniors like me, I guess, but Manny Pava, who's in charge of running one of our stroke programs here at St. Joe's, as well as Karen O'Neill, who is one of our physical therapists that works on the stroke unit, and a patient partner, Vern, who will be joining us online. Vern, you can just turn your camera on and unmute yourself. And then we're fortunate enough to have Dr. Teasel again moderate this panel discussion that we can reflect on the information that Marcus and Amanda shared with us. So Dr. Teasel, I will pass it back to you. Thanks.
All right, so I think you can see from what we've heard that we kind of believe that we're at an inflection point or a transition period now where we are establishing a large amount of evidence and we're starting to see a lot of development of these new technologies, and people now are just starting to become acquainted with them and start to use them. So I think we wanted to have a bit of a reflection though in trying to better digest what we've heard in terms of the evidence and getting the patient and the clinical and the administrative sort of impression of that data and just a general discussion on the use of technologies in stroke rehab. And so I thought I'd start first with you first, Vern. And one of the things that the question I have for you is, what technologies did you utilize in your treatment and were they helpful for your rehab and recovery?
Okay. Yes, I did try some of these different things that you're referring to. Probably the most significant one was, and Karen's going to have to help me here, with the robotic piece of equipment.
The Lokomat.
Sorry?
The Lokomat?
Lokomat, that was it. That was quite a piece of equipment. I was astonished, quite frankly, with it. It was very difficult to get into and get out of, as Karen will attest. But that was extremely interesting and extremely useful to me.
Did you use any other technology, Vern?
Yes, we did. We used electrical stimulation. So that was because the thing that I was going through was the inability to operate my lower right limb, my leg, knee, and foot. And so Karen set up the electrical stimulation for me so we could actually, for me to get used to walking by landing the heel first and then the toe, because part of what happened to me, it was almost a form of drop foot. And so the danger of that, of course, is when you walk forward, the toe lands first and you can trip, which of course is extremely dangerous. So that piece of equipment was basically trying to force my heel to land first and then the toe. And there was a rhythm to it, which Karen could control.
So was it your impression, Vern, that they helped your recovery?
Absolutely.
Okay. Now, Vern, when you became an outpatient, were you still able to access the technology? And do you think that would have been important to you?
It wasn't offered to me. There was a little bit with something called a twin stim that was suggested to me. There was one in the outpatient, but it was suggested that I buy one, which I did. And I used that probably not as frequently as I did, but the idea is that one of the things I'm suffering from is the calf muscle is one side appears to be weaker than the other. So there's an imbalance. And so my right foot curls under. And from what I can understand, it's simply because the stroke has weakened one side of the calf. And so the other one has taken over and overpowers the limb so that my right foot tucks underneath. Unfortunately, also as a result of that, I had curl toe or hammer toe. It then became curl toe. And on June the 7th, I had to have surgery to straighten my toes on the right foot. And I'm in a boot right now.
All right. All right. Well, thank you very much, Vern. Karen, we summarized a lot of data, evidence for technology and survey of technology use. As a practicing clinician, I'm interested in your comments on that before we ask you some other questions. What did you think of that?
As a clinician interested in knowing what technologies is out there, it's always difficult to kind of stay on the forefront of all the things available and to what efficacy they are. So, Marcus and Amanda did a great job presenting all the different types of new technology out there. And honestly, at times it's quite overwhelming hearing about all the different options out there, and overwhelming in the sense that trying to figure out what would work best for our patients depending on what presentations they have, be it upper extremity, lower extremity, communication, and then the burden of maybe learning all these devices and hoping after becoming a little more expert in them that they're actually quite efficacious in our treatment with our patients. So I think it's my initial reaction is the excitement that all these technologies are coming to the forefront that can better help and serve our patients, but also the intimidation of trying to learn all these devices and use them effectively in practice.
So you've indicated some of them, but can you give me a kind of a rundown of the type of barriers that exist for you when you want to try and implement a new technology?
So Amanda did a great job summarizing kind of, first of all, is the awareness. I think at Parkwood we have, we're very fortunate to have exposure to a lot of these technologies. And the next step of that is learning these technologies and becoming expert at them. So the primary barrier is getting access to all the technologies and then implementing a training system for the clinicians to then work together to learn these devices and learn who they're best applicable for. And then not only is it just setting up the patient in the device, but understanding when to intervene in their stroke recovery, with what timing, what dosage, how often, and then keeping in mind that there's a lot of other things that we have to work towards aside from integrating technology, but which is, discharge planning, working on functional goals, and then ultimately what the patient's goals are as well. So trying to incorporate all that together in our clinical practice and their short length of stay is kind of the biggest barrier I feel we're running into. So
what would you think is needed to help you incorporate a new technology into your practice?
So what Marcus and Amanda does is bringing kind of to the forefront which emerging technologies are most efficacious to better kind of treat our patients, to what effectiveness it is. And then on top of that, having access to the equipment. So having the equipment available here at Parkwood, organizing training sessions for us clinicians to, feel comfortable implementing these technologies with our patients. Here at Parkwood, I think we're also very fortunate because with Dr. Dalton Wolf and his committee, Steph Cornell, another clinician here, we've integrated the training and coaching model. So as clinicians, we all kind of group together. We support each other in the development of expertise within these technological devices. We've set up a training and coaching model here where we have champions or experts in certain devices where clinicians can reach out to help set up these patients appropriately on the device, problem solve through use of the device to ensure that we're doing it correctly.
Okay, good. And I would assume then that, one of the things we're interested in is how the Gray Center is going to help you to do that. And I think you've nicely described the ways in which we can help facilitate that process, as it were.
Yeah, definitely. I think one of the biggest benefits of the Gray Center involvement is the marrying of the researchers to the clinicians. and bring them together into one center where the researchers come forward with kind of the dosage, timing, what's being said about the efficacy of how to use these technologies, and then integrating that into practice. So where I've seen the Gray Center is the marrying of that research and clinical sciences, and then having working together with our coordinator. I'm sure Mandy will speak to this as well, but supporting the clinicians in the ability to get training on these devices, have them accessible to us, and then supporting us in developing our skills towards that. So the Gray Center has been really helpful in the sense of coordinating between clinicians, coordinators, researchers to ensure that we are using these devices to their fullest potential.
Okay. Well, thanks, Karen. And you mentioned Manny, so I'm going to turn to Manny Pava. Manny's a occupational therapist and coordinator of stroke rehab unit, and he's the essentially he's our administrator today. He's the person who has to figure out a way to make the environment a way to make all this happen. And so, Manny, my question for you is, how do you or would you promote and encourage the use of technology interventions on the stroke rehab unit?
Yeah, thanks for the introduction. That was a great question, Bob. I think for myself as the program coordinator, it's really trying to use some of those recommendations and guidelines that are already out there, like the Canadian Stroke Best Practice Guidelines, the evidence-based rehab recommendations and principles that are available through many of the reviews. We also have practice standards through accreditation, stroke distinction that we're striving to meet. And I think my role is really looking at all of those, really trying to raise awareness within them, within our team members. Again, if there's updates to them, if there's changes that are coming forward, but also having a process to review how we're doing, looking at our current state, doing a good gap analysis, seeing how we're doing, as a program with our service delivery and how we meet those. And then it really, as Karen alluded to, it's helping the teams come up with action plans to try to meet those standards and to try to get there. Again, within everything else that we also have going on within the program, that it is a priority. So I think that's how I see myself helping. I think that's where my biggest role is. But then also, like you talked about how I see the Gray Center helping, and some things that I have already seen and Karen would have already alluded to is, again, helping to bring some of those recommendations, the information that you're seeing from the research studies that you're doing, some of that new evidence, and then working with us together so that how we can implement that with our clinical teams and being able to work closely with our clinical teams to do that. Some of the really cool stuff that I've seen happen already is to talk about Dr. Sue Peters' study that she has going on. And I've seen the integration that she's been able to do with her researchers and the clinicians on the inpatient team, and how they've been able to start conducting some of that research already in situ, like right on the floor. So that's some pretty exciting stuff I've seen come forward already.
Now, I don't want to put you on the spot, but can you give us an example of something that you would be using clinically, a technology that you've been trying to introduce onto the unit?
Yeah, absolutely. That's another great question, Bob. So I think a couple things I want to talk about. The one that we've put the biggest emphasis on, so I wasn't surprised to see that in the recommendations, was FES, or the functional electrical stimulation. So we did put a lot of effort into, again, just giving our clinicians the time to even learn about it. So there's a lot of modules out there that we have that are available to us directly through the company that we buy our FES equipment through. So making sure that they had the time to actually even do those modules. And then, as Karen talked about, is coming up with a champion. So somebody who wants to take the lead on helping the other clinicians to set individuals up on the equipment, problem solve, ask questions. And then that champion kind of also helps really grow the FES strategy within the program. So that's something that I've seen be really successful on the inpatient team that we have done, and it has really facilitated our use of the FES on the inpatient program. Even to say that we've done that we've been able to successfully with the support and the encouragement of some of our other colleagues, we've been able to get an FES bike actually on the unit. So it makes it a little bit more accessible for our patients to use and for the therapists to use as well.
So, from an administrative standpoint, what are some of the barriers that still exist to incorporating new technologies onto the rehab unit?
Yeah, that's another great question, Bob. I think it can also change too. So if you ask me right now, I would say the biggest barriers are probably staffing. To be completely honest, it takes staff to also be able to run these pieces of equipment, right? So even some of those robotics, even the FES, it takes time to get people set up on those. So you want to make sure that you have the right support in place to also be able to facilitate the use of the equipment. I also want to say potentially right now is prioritizing. So as Karen alluded to, we want to make sure that we're hitting all of our markers, in the patient's best interest. So yes, of course, it is important to really stress and implement these evidence-based practices, but we also have organizational things that we are trying to promote and prioritize. Plus, at the end of the day, we also really need to make sure that our patients are being seen and that intensity is there. So putting all of that together, I think, is just also trying to prioritize to determine what is the most important. And the third thing I would have to say is probably funding, right? So trying to find, adequate funding to be able to purchase these things, because we know they can be quite costly. So just being able to help the team, being able to find resources for that type of equipment. And then, again, I could say that is something that I have seen the Gray Center help us with, and that I could see real success moving forward is through some of the equipment applications that we've been able to do and submit for approval, again, to try to help get access to that equipment at the facility so that we can really learn how to implement it in the best way.
Okay, thanks, Manny. I thought I'd bring up a point and just kind of get the panel's opinion on it. And it comes out of the survey data that Amanda was talking about, but she didn't show the data. But when we were looking at inpatients versus outpatients, in terms of therapists applying newer techniques, including technologies, what I really found fascinating and was totally unexpected was that the outpatient therapists were more likely to apply new therapies. These sort of adjunct therapies were more likely to be aware of treatments and were more likely to utilize them, which I really found fascinating. When I gave it a lot of thought, it made a lot of sense to some extent, because on the inpatient unit, you're really focused on, you got to get the patient walking and I got to get them independent and I got to get them out the door in a tight time frame, right? And now you're talking about using technologies. It's not that easy. Whereas in outpatients, you're dealing with a little more flexibility in a patient that's starting to plateau and you're willing to experiment on a different level. I'm wondering if people wanted to comment on that at all. You know what I mean? Because there seems to be, we noticed a difference between the use of these things on it wasn't certainly Vern's experience on an outpatient versus an inpatient, or the willingness to use them on an outpatient versus an inpatient setting. And I think that might reflect some of the time pressures that people are under and some of the things they have to do. I'm just wondering if you could comment.
Would you like me to comment?
Sure, Vern.
I found the opposite.
Yeah, I know.
I found that inpatient, I had access to a lot more equipment, and it would appear to be more up-to-date equipment than outpatient. Outpatient to me was a lot lower level, if I can say that, in terms of technology that was offered to me. And then it fell off from there to when I was discharged and go home.
Okay.
So it was, I just felt we were stepping down.
Okay.
That's a good point, Vern. I wonder too, if also just to kind of speak to what Karen was talking about earlier, also about that, the dosage and the right time and, kind of the frequency and stuff like that, and whether or not that also plays a part about the timing, and, when some of this, this equipment is being, put forward and recommended for patients as well.
Yeah, Manny, good point, and thanks for your feedback there, Vern. In my opinion, with inpatients versus outpatients, it's a little difficult in inpatients because a lot of the research centers around the most recovery occurs in the first 3 months, and it's difficult to integrate a lot of the various technologies if we're not sure of the efficacy of when to put them on, what dosage to put them on, and what timing it is. So Dr. Teasdale, you made a really good point with in outpatients, we tend to have maybe these individuals have plateaued or we have an idea of where they are, and then we can implement the most appropriate technology at that time. And then in patients, like Manny alluded to, there's a lot of other organizational and prioritization that we have to focus on in inpatients, which makes it difficult to integrate the technology. And then on top of that, we know that, repetition and intensity is what optimizes neuroplasticity and functional recovery. But we also can't forget, the aspects of specificity, salience, and transference that we're not exactly sure these robotics can achieve during that inpatient stay. And then also making sure that there's no interference with the stroke recovery and or rehab in that sensitive period of time. So again, with the research coming about with these new technologies, seeing if we can optimize those other aspects of neuroplasticity and neurorecovery within the technologies, it's going to be where I see research and technology going, and obviously will then impact the availability of which technology to use in the inpatient versus outpatient setting.
Okay. So
Bob, I just have to add because I see a lot of our community team members on here too, is it's definitely something that we have to consider, right? Because even with our community stroke rehab team, they're going out to individuals' homes and in community settings, and how do we get some of this technology there into those settings? But also, or, again, is it something that we can work with the Gray Center on with, having, access to some of this technology that some of those community individuals could access? Again, just a thought, but something to consider for sure for our community individuals as well.
Okay, I have sort of a final question, and it's the $64,000 question we always ask in these types of settings. And I think it's one of the things that's really critical to the Gray. As you know, in research, there's often a disconnect between the research evidence and then how quickly and how thoroughly that then gets applied to clinical practice. It's the great chasm, as we call it. And do you have any ideas how to better bridge that gap? I mean, we've kind of touched upon it, and this is for all of you. Any ideas how we better bridge that gap? Because I think those are real critical questions for the Gray. How do we bring this evidence together and actually apply it better to clinical practice? So just curious, maybe we'll start first with Marcus. Any ideas you have on that?
I guess none specifically. Obviously, I'm no clinician myself, so it's difficult for me to speak exactly to it. But I think to a certain degree, it seems like Manny and Karen mentioned. But really, I think a big part of it is dedicated time that's put aside to learning these things. If there is, not necessarily an expectation that one might go out on their own to try to summit this mountain of evidence. I think if it's broken up into more manageable chunks and there's that dedicated time provided, whether, on an administrative level or within a clinician's day, where they can review the evidence, discuss amongst colleagues, and really get their heads around a particular issue. I think that building that in as a part of their practice, as a part of their day, is something that can really help, similar to, as researchers, a journal club every week or every month where ideas are discussed and these various studies, various investigations can be brought up by anybody who's interested and really broken down so that they can walk away having understood what that particular piece of evidence says.
So Karen, though, brought up a good point. She kept coming back to it, is this idea of who and when, you know, in terms of research. And you and I have talked about this many, many times, trying to that personalized medicine, right? That trying to individualize this amorphous data to the individual patient, which is always the clinical challenge. Any ideas on how we can get better at that from a research standpoint?
Who and when?
Yeah.
Yeah, I think that is a tough one, especially when it comes to looking at the overall evidence can kind of point you up or down, left or right, but getting into the specifics of and in what particular manner definitely becomes a greater challenge. I think to a certain extent, there are some therapies that can lend themselves naturally to certain periods of time or certain disability levels. I think a great example that Bob, you often use is exoskeleton robotics. For somebody who has a decent amount of upper limb capability, let's say already, and you're looking to refine some dexterous movement and ensure accuracy in movement, I think there are other therapeutic options available. But in a sense, for those who have severe disability and are incapable of producing even basic movements on their own, that's where an exoskeleton can really come in and provide a patient with the ability to get that range of motion that they need and the various movements that they would otherwise be able to apply. I think to a certain extent, you know, for what it is, in my opinion, who, what, and when is something that a lot of the literature is still trying to figure out. I don't think there's necessarily an answer in there for a lot of those questions and a lot of these different interventions. But more than anything, trying it, exposure to it, I think is beneficial. And in that sense, I would imagine that a clinician can sort of gain a clinical experience and understanding of who and how and what, because the theory is one thing, but in practice, to be able to understand an intervention fully, I think that's where clinical experience can really take over and essentially inform, you know, a particular therapist's decision on who and when.
Excellent. Jeff, you were gonna
I just want to, this has been a great discussion, but I want to open up the floor to some questions from the audience, if there are any, with our remaining few minutes. Audience members, everyone now has the capability to unmute themselves. So I think I saw a couple hands like virtual hands get raised. So if you want to unmute yourself and then direct the question at either a specific panel member or to Dr. Teasel, we can hopefully quickly chat about your particular question. And if there's no questions there, Dr. Teasel, then maybe one more to the panel would be good, but we'll open it up to the audience.
This is Anu here, and I work in acute care at University Hospital. And this question is for Marcus. Marcus, thank you very much. That was like a great body of evidence that you really put together very nicely. My question to you is that at what stage of their stroke was the technology used? In the sense, what I'm asking is, was it within 5 days after stroke? Was it 6 weeks after stroke? Was it 3 months after stroke? Because that is very important to see where the technology goes.
Yes, great question. I think for the most part, when we deal with randomized controlled trials, there's a big range, frankly. I would say that it's at least, in general, a week after the stroke. It won't tend to be before that. But the majority of data in stroke rehab really does focus on the chronic patients. So patients that are, let's say, greater than 6 months past their initial injury. That's where a lot of the data exists. For a number of reasons, they're certainly more easy to recruit after they finish their inpatient stay. And I think additionally, any of the effects of the spontaneous recovery that does occur in that initial 3-month window that Karen had alluded to is negated from the actual study, so you can focus on the intervention itself. But I think even if it's not on the patients in the acute or the more subacute phases, the fact that we are still able to see these changes occurring in these patients' functionality 6 months plus, a year plus, is encouraging evidence for the use at any point in time during therapy, which I think speaks to the effectiveness of some of these technologies. But overall, to answer your question, I think it depends on the intervention. Like I said, some are certainly more applicable in the acute phase than others, but in general, I would say almost half of the literature, if not maybe 60%, focuses on patients who are greater than 6 months past their stroke.
Thank you, Marcus. Just a follow-up question. Sorry.
Sure.
I mean, did you come across any studies where they looked at how long did the effects of this technological interventional recovery were retained by the patient?
That is another great question. There are certainly some studies that aim to try to assess follow-up retention on the 6 to 12 months, maybe 2 years even past the initial end of the intervention period. I would say anecdotally that not many studies do that. And if they do, the retention period is about a month, maybe 3 at the maximum. So I think a big push, at least from my understanding, within sort of this next wave of stroke literature and stroke research is to try and do a better job of something that we're not quite capturing that well, given how much evidence is out there. But there are some studies that do assess those long-term retention effects, but they are few and far between, unfortunately.
Thank
Move to
you.
the next, BJ Orange, I see your hands up.
Thanks, Jeff, Bob, and Marcus and Amanda for a wonderful presentation. It's very productive and useful. My question, and it's not directed at anyone in particular, is the issue of remote sensors. And I hadn't heard much about it. And I'm wondering if there's a role to be played by these remote sensors in terms of at least addressing some issues around compliance or adherence or treatment fidelity that goes along with some of these types of technologies. And I'm wondering what the role is for them. Thanks.
Who wants to tackle that one?
I can speak to the evidence maybe first, and then someone can certainly pick up on the practice, but it's definitely a growing area, this sort of remote sensing of a number of different aspects of recovery, really. Oftentimes they are IMUs or kinematic sensors that are put on various joints. And whether it be, a daily step count, simple as a pedometer, or oftentimes you're looking at velocity within various gait patterns. You are looking at particular angles within the joints to assess the quality of the movement. I think there are a number of different applications. They all center around, for the most part, providing a certain amount of feedback, both to the patient and, importantly, the clinician, who, and as we talked about in these outpatient settings, might not have as much access to that patient. You see them a few times a week and you send them away with a number of exercises. I think these sensors really do provide an opportunity to, from a clinical perspective, as the provider of care, gain much better information on the quality of movements that are being performed, how much is being performed, and how you need to manage that specific patient's case as time goes on. So the literature is there and it's growing significantly, and I think provides a good connection between a patient who isn't physically in the hospital anymore and their clinical care provider.
Thanks, Marcus. Shannon? Yeah, I think you're on mute there, Shannon, so you might have to unmute yourself if you're still there. But if not, we'll just go to Fabian, and we'll loop back to Shannon in a moment.
Hi, I have a question for Vern. Vern, my name is Fabian. I'm a physical therapist. I'm just wondering, based on your experience at Parkwood, what would be your wishes for technology use at home in the community? What you would like to see happening? You said that you had some experience that was less than desirable. So I'm interested to hear from you what you would like to see happening.
Well, I think from my standpoint, of course, when I was an inpatient, one of the things was that there was a schedule set for every day, perhaps except Sunday, to go to physio. And it was very well organized. It was very timely. And I spent 5 weeks at Parkwood doing that. Then when I became an outpatient, of course, the number of visits was twice a week. And because of the pandemic, there was a problem with that too. So that impacted it somewhat. But I found that I was in a situation where I don't want to be critical, but it was sort of, let's try this, see if that makes a difference. Let's try that. Let's see if that makes a difference. And I didn't have a lot of confidence in what was happening. And when I was there, it just gave the environment, it looked to me, it was all, low tech. It was sort of games and things like that. And I just didn't enjoy that part. And then, of course, when I was ran out of my OHIP there, I had to do things at home by myself, which I have been doing. But with no supervision, I mean, it relies on the patient to make sure you continue to do these repetitions of exercises without a lot of the equipment that we've been talking about.
So it sounds to me, Vern, like you would have been interested in accessing that kind of technology in outpatients as well.
Yes, that's it.
Excellent. Excellent. All right. Any others? Questions, Jeff? Any others?
No, I think that's it. Shannon logged off. So this has been a really enlightening discussion. So I thank all the panel members, in particular, Vern, really thanks for sharing your experience. I think it's really valuable for everyone to understand the patient lens, perhaps more than anything else. So thank you for your time. To Amanda and Marcus, thank you for sharing your research. And Dr. Teasel, thanks for moderating the session. Everyone else, enjoy the rest of your day and have a happy long weekend. Thanks a lot.
Thank you.